So welcome to this meeting entitled Financing Global Cancer Care. Welcome here to the London School of Economics. This event is hosted by the Global Surgery Policy Unit, which is a collaboration between the London School of Economics here and the building next door, the Royal College of Surgeons of England. My name is Rachel Hoggins. I'm one of the co-directors, and you'll be meeting Dr. Rocco Freeball, one of the other co-director, later this evening. First of all, I'd like to thank Dr. Susanna Stanway and Dr. Katie Wakeham, the organisers of London Global Cancer Week, for inviting the Global Surgery Policy Unit to host this event as part of their week's events. And also to thank our Global Health lead at the college, Ms. Rosemary Amodi, and particular thanks to Maeve Bognini, one of our researchers here at the GSPU, without whom this event would not have been able to take place. She knows all things technical. So I'm just here really as the warm-up act for the health economists who are going to do the main part of this meeting. And I think with any problem, being a surgeon myself, you need to know what is the scale of the problem that you are dealing with. I have no conflicts of interest. So the first couple of slides take some statistics from the most recent GlobeCan global cancer statistics from the Global Burden of Disease paper. And in 2022, there were just shy of 20 million new cases of various forms of cancer worldwide, leading to about 9.7 million deaths. The slide shows the 5 commonest cancers worldwide, and any clinicians in the room will recognize these. Whichever part really of the world you practice in, these are pretty common cancers. But the point I want to draw out from this slide is that incidence and death rates don't necessarily correlate one with the other. So as you can see, for the gender-related cancers, breast in females, prostate in males, the death rate is actually lower as a percentage of deaths than the percentage of cases, because certainly in high-income countries, earlier diagnosis, better treatment, etc., is available. Whereas if you look at lung cancer and gastric cancer, the death rate exceeds the proportion of cases, of new cases that are due to those conditions. And I think all of us know that lung cancer and gastric cancer, unless caught early enough for surgical resection, really portend quite a poor prognosis wherever in the world you happen to be diagnosed. Colorectal cancer, I'm a colorectal surgeon, which I guess is my conflict of interest. We're sort of bang on the middle there, so we're doing okay. Now, obviously, gender has a big issue here, but the point of this slide and the next one is regard to the inequalities in distribution of the gender-related cancers and others. The cancer incidence, what is the most commonly diagnosed cancer worldwide? And in 118 countries, that is prostate cancer for men, followed by lung, and then various of the abdominal cancers. In women, it's overwhelmingly breast cancer, with then cervical cancer coming up second, and very few other cancers make the sort of top of the chart you don't want to be top of in women. Now, obviously, there are issues about the validity and diligence with which cancer statistics are collected in various countries, and the way in which deaths, as we see on the next slide, are certified. Again, you can see that for men, lung, prostate, liver are the 3 big killers. In women, breast overwhelmingly, cervical significantly, and then lung, unfortunately, becoming more common. But particularly for women, if we could focus on breast and cervical, so that the lowest income countries in the world with the most precarious health services were able to perform even to the sort of average of some of the higher income countries, on a worldwide level, that would make an enormous difference, and it does sort of show us where the big killers are lying and where we should be perhaps prioritizing things. Now, as obviously the propensity of a certain cancer to kill you partly depends on the biological aggressiveness of that cancer. Irrespective, I mean, there are some cancers which, even if you have all the money in the world, the best treatment in the world, access to go anywhere in the world, we can all think of some famous figures who've had horribly aggressive cancers of particular types. But overall, breast and cervical for women, lung, prostate, and probably liver for men are probably where we should be emphasizing our work. This is the graph which really shows the inequity on a global distribution. So if you look at the cases on the left, if you look at Asia, which is in the dark navy blue, obviously Asia has a huge population, so we'd expect a lot of the cases to be there. And overall, it accounts for about half of the cases of cancer diagnosed worldwide. But you can see Asia accounts for way more than half of the deaths worldwide. And likewise for Africa, although smaller in objective terms for both cases and deaths, you can see that the light blue slice of this pie for cases is smaller than for deaths. So Africa has a disproportionate number of deaths. And then the converse is true for the richer parts of the world. If you look at Europe in the orange and Americas in the green, both of those account for between 20 and 25% of cases, but they account for less than 20% of deaths. Now, this isn't rocket science. I mean, I think we all know that if you have cancer in Europe or North America or Canada or somewhere, you've probably got access to better healthcare than in parts of Asia and Africa. But I think this kind of figuratively shows us the issue of global cancer care and where the inequalities lie. And it's even more poignant on this slide. So the Human Development Index, many of you will already know about this, but for those that don't, it's a measure that not only accounts for the GDP and the financial position of a country, but also it's a scale that includes things like educational level of their population and some of the sort of social structures that are there. If you look at incidence on the left of each graph in the navy blue columns, you can see that in the very high Human Development Index countries, that's Western Europe, North America, there's a very high ratio between incidence and mortality, where probably only about a third or even less than a third of cases of cancer lead to death. But as you come across from left to right, from the very high developed countries through to the low developed countries, you can see that there is a higher proportion of deaths relative to the incidence of cancer. But what's also interesting is that if you just look at the navy blue bars, the incidence of cancer is obviously higher in the high income countries or highly developed countries. Now you could say, well, firstly, they've got older populations, yes. Secondly, they've probably got better diagnostics, yes. So you would expect their incidence to be higher. And you could say this is a quirk of statistics. But these figures are shown as age standardized rates. So that should take into account the fact that you have got an older population, and particularly for the deaths. If you look at the orange bars, particularly for women, there's actually very little variation in the death rate. In fact, if anything, it's higher in the lowest developed countries compared, and it doesn't reflect the incidence, which is much lower in those countries. So this is the scale of the challenge that we're up against. Now, what are the factors that may influence these figures over the next 20 to 30 years? In general, apart from in countries which have slid backwards into famine or war, there is increase in life expectancy. The Millennium Development Goals have been very successful as regards things like maternal and child health and mortality in the first 5 years of life, vaccination programs, and emphasis on the health of infants has actually been very successful in a number of countries, such that people don't, or children no longer die to the same rates, at the same rates of those things that killed small children years ago. And generally life expectancy is going up, but that therefore brings with it the fact that cancer incidence will go up. There are things that can be dealt with by legislation. We've seen it here in the UK. Many other countries have legislation about smoking, about health and safety at work and exposure to carcinogens and so on. And there's good evidence that the rates of cancer related to those carcinogens in well-regulated countries is much less than in countries which have very little. This again brings in the global equity thing. Is it right for rich countries to be offshoring their waste disposal, their breakup of shipping and things like that, which are no longer able to be done at cost effectiveness here in the global north? Is it right to export those risky industries to the global south? And then what about infection? Probably the best example is regarding to HPV virus. Many countries have instituted vaccination programs for HPV vaccine for girls, and in some countries for boys as well. And one of the exemplar countries here is Rwanda, which has extremely high uptake in teenage girls of almost 90% coverage with HPV vaccine, which is way above what we can achieve in the UK. I was reading something on the train, a very long delayed journey today, I had time to read a lot, about Helicobacter in China. And it was an interesting paper where they had calculated that if you could get universal coverage for Helicobacter eradication in China, you could prevent 1/3 of the cases of gastric cancer being one of the leading cancers in that part of the world. So there are things which potentially could be done at scale, which not only would reduce the cancer burden for patients, but actually be very cost effective. And then some of the things which we will talk about tonight in terms of policy, universal health coverage, I'm sure that's going to be covered. We do have to be a little bit careful that things like improved diagnostics and improved data recording may make the incidence go up and therefore make the death rates look proportionately better in the future, which we need to be careful about that. And then, of course, there are the left field events, the conflicts and disasters and pandemics, which can overwhelm a country's health system. We can think of countries which 10 years ago, Lebanon, Ukraine, Syria, had pretty good functioning health systems, but have been practically overwhelmed by events that have happened in those parts of the world. And who's to say that they couldn't happen elsewhere? So this is one calculation from the GlobeCan study of where we might be headed. And there is an estimate that over the next sort of 25, 30 years, the total number of cases will go up from 20 million to around 35 million. But what is the worrying thing on this graph is that the biggest proportionate increase looks as though it will happen in the lower income and lower developed countries. Ones potentially with the health systems which are the least robust to cope with this. Yes, it's great that life expectancy is improving, but the fact that smoking is on the rise in many countries, industrial legislation is rudimentary in many countries, and there's also the issues about obesity, diet, etc. Perhaps this is the most worrying of the slides. So, predicting the future, always a risky thing to do. We all know about the known knowns, the known unknowns, and the unknown unknowns. We've been discussing last week's unknown unknown. It happened a week ago today in this room before we started the meeting. And as they say, it's the latter category that tends to be the difficult ones. But what about potential solutions? So I'm just the doctor here tonight, so I can put the problem. What we've got here tonight for you is actually a panel of expert health economists. I'll introduce them briefly now, and then as each of them speaks. So we have Professor Rifat Atun from Harvard, Dr. Robert Yates, who I've put down as both the London School of Hygiene and Tropical Medicine and the London School of Economics. It's his first day here today, so be nice to him. And then established members of staff, Dr. Rocco Friebel, who I said is the co-director of the Global Surgery Policy Unit, and Dr. Marcello De Finici, who's our Assistant Professorial Research Fellow. Now, Professor Atun was hoping to be here in person, but he is, I think, in the air somewhere, having been called back to Harvard. So he's kindly sent us a virtual presentation, which I may need some assistance with in sharing with you. And he's going to talk to us about creating the fiscal space to finance global cancer care.
It's a real pleasure and privilege to contribute to the London Cancer Week. I'd like to thank the organizers and my colleagues at the London School of Economics for inviting me to contribute to this panel. My presentation is going to focus on investing in cancer control. I'll first share 3 case studies in relation to development of an investment case for investing in cancer control. Then I'll explore potential sources of funding for providing financing for these investments. So there are 3 pathways to creating better health and economic benefits through investments in cancer control. The first is by investing in cost-effective interventions, reducing the cost of illness. Secondly, by improving longevity and well-being of individuals, contributing to human capital and ensuring productivity gains for the economy as a whole. And the third is through economic activity as a sector, both generating value in the sector but also in adjacent sectors. I'll first talk about the generation of value and health and economic benefits through investment, developing an investment case for cancer. So what is an investment case? Well, first, this is an approach that provides an organizing principle for a core set of actions. It emphasizes health and economic benefits of interventions. And 3, it changes the narrative from costs to actually getting a return in investing in health, both health returns but also economic returns. It also provides a clear timeline and a time horizon for the actions, cost, and returns. I'll share 3 case studies to demonstrate what the potential benefits of investing in cancer and the scale-up of these interventions might be. The first case study is investing in the scale-up of radiotherapy. This was a Lancet Oncology commission. I had the privilege of co-chairing with colleagues that included leading clinicians and practitioners around the world. In the study, we were able to estimate what the cost of scaling up radiotherapy interventions might be in the period 2015 to 2035, working on 2 models, a nominal model and an efficiency model. And we're able to estimate both the cost of scaling up interventions, but also the benefits, both human capital benefits, but also full income benefits. And as this figure shows, we can see that fairly quickly, within about 5 years of scale up and investment, the benefits accrued actually exceed the investments that are made. In fact, if we look at the returns on investment, there are very large benefits. For example, using the full income approach in low-income countries in the period 2015 to 2035, using the efficiency model, the benefit in low-income countries would be $12.8 billion in terms of net monetary benefits. In lower middle-income countries, the benefits would be $67.7 billion. And in upper middle income countries, the net economic benefits would be $284.7 billion. In terms of the return on investment, in low-income countries, the returns would be for every dollar invested, $0.9. For lower middle-income countries, it would be $2.03. And in upper middle-income countries, for every dollar invested, the returns would be $5.77. So fairly substantial returns in economic terms, but also fairly substantial returns on investment. And this study was important in dispelling the myths that radiotherapy is complex, it is expensive, it's not going to produce the right benefits, whereas we're able to show that none of these myths are actually correct, and we're able to generate substantial health and economic benefits. The second case study is another Lancet Oncology Commission on sustainable care for children with cancer. And in this Lancet Oncology Commission, again, which brought together leading experts as well as civil society and patient groups, we developed a microsimulation model to estimate and project incidence, survival, deaths, cost of scale-up, and as well as economic returns. And we're able to show through the simulation model for the period 2020 to 2050, the lifetime cost of a scale-up would be around $594 billion for 200 countries and territories. Again, over a 30-year period, this is not a very large sum spread over 200 countries. But what was very important in terms of findings was that the productivity gains were very substantial for children who were effectively treated using chemotherapy, surgery, or radiotherapy, and children who were diagnosed early. So the net benefits were around $2 trillion. So overall cumulative productivity gains we estimated were $2.58 trillion with overall cost of $594 billion. The net benefit was $1.986 trillion with a net return of $3 for every dollar invested. Next, we applied the same principles and extended the model in another Lancet Commission, which this time focused on 11 adult cancers. And we included in the model a scale-up of surgery, radiotherapy, chemotherapy, as well as imaging diagnostics, ranging from X-ray, ultrasound, MRI, CT, PET, SPECT, and so on, as well as more advanced forms of therapy. And we looked, again, over a period of time what the benefits would be in scaling up interventions in 200 countries and territories. And we estimated that the incremental cost would be $232 billion. And this would amount to an increase of 6.9% in the current cost of cancer services. But the lifetime productivity gains would be $2.89 trillion with a net economic benefit of $2.66 trillion. And the return on investment on average across the 200 countries and territories would be $12.43 for every dollar invested. And in Europe, the benefits would be $4 to every dollar invested. And we can see from this map that the level of returns would vary from country to country. In Latin America, these returns would well exceed into double-digit figures, into around $50 to $60, even $70 return for every dollar invested. So there's a compelling case in terms of the human capital benefits of investing in the scale-up of cancer interventions. We talked about three pathways, and the third pathway is the effects of investing in cancer and its direct benefits to the health economy, but also benefits to the adjacent sectors and benefits in terms of gross value added through induced income. This is a recent study that we're still working on with colleagues at Weifer Institute in Germany. And looking at the United Kingdom as an illustrative case study, we're currently estimating that direct effects of investing in cancer in the health economy, given the current investment levels, is for every pound invested, there is a direct effect of 0.8 pounds in the health sector, generating 6.2 billion pounds of activity. In the adjacent sector, the gross value added for every pound invested is 0.58 pounds, which provides an additional economic benefit of 3.7 billion pounds. And third, the gross value through induced income for every pound invested is 0.73 pounds, generating an additional 4.7 billion pounds of economic returns that contribute to economic growth. So there's a compelling case in investing in cancer control, but also scaling up interventions to realize both health and economic benefits. But the question is, where will the money come from? And this is something that my colleagues on the panel will discuss in more detail. But I want to provide a very quick glimpse of the potential sources of financing, looking at the fiscal space that might be available. But before that, it's very important to change the narrative from cost to investment and to demonstrate the substantial health and economic benefits of these investments. Because all too often, industrial policies push and encourage innovation, whereas health policies tend to constrain the scale-up of innovations. And economic policies do not take into account adequately the substantial contribution the scale-up of innovations could make for cancer, but also in the health sector in general. So the new funding could come from conducive macroeconomic conditions that leads to additional revenue generation through general taxes for the government to be invested in health, for example, as Brazil and Turkey have done, or countries could reprioritize government expenditures or budgets to invest more in health, for example, Mexico. A third potential and important source is sector-specific domestic revenue sources through taxes on tobacco or alcohol or sugar beverages. A very good example is from the Philippines that have generated very substantial tax revenues from tobacco tax to invest in expansion of universal health coverage. Or one could borrow to invest through concessional loans, for example. And there are many countries during and after COVID-19 who have done that to expand and scale up interventions in the health sector. Or one could introduce appropriate priority setting to improve efficiency and effectiveness of the budgets in the budget allocation in the health system, and generally efficiency and effectiveness of the health systems, as, for example, Thailand has done, including the UK through NICE. And finally, one could apply innovative financing mechanisms, for example, social impact bonds or blended financing, for example, India, that have been able to apply this to scale up interventions for funding priority areas. So I'm sure this is going to be discussed by my colleagues on the panel, and I'd like to thank once again the organizers and my colleagues at LSE for inviting me to contribute to this session.
So I think that's nicely set the scene for us now for our panel of speakers here. Just to say that we will be taking questions both from the audience in the room and from the audience online. So if the online audience want to type in their questions, they'll be gathered here and you'll get the chance to have your question answered. But what we'll do is we'll take the three presentations one after the other and then bring the panel together to do all of the questions. So it's my great pleasure now to introduce Dr. Robert Yates as our next speaker. He, as I said, has just started at LSE today as a visiting professor here. He's also visiting professor in practice at the London School of Hygiene and Tropical Medicine. And he's previously been the executive director of the Centre for Universal Health at Chatham House and has been a long-term consultant to the elders on their Universal Health Programme. He's going to speak to us today about marketing cancer control systems to ministers of finance and political leaders. Thank you. I think we...
Thank you very much, Rachel. Thank you. And thank you very much to Rifat for setting me up beautifully there with this tricky question about where are we going to find the financing, how are we going to get the financing? And I think very important to recognise this as Rifat finished there with his final slide about sort of where are the potential financing sources. you might notice that all the mechanisms he was talking about there were public financing mechanisms. You know, there wasn't sort of any suggestion that, you know, we could get more money by sort of shaking down the population and expecting them to pay user fees, or private health insurance being a good route. So I'm delighted that he said that. And I think had we been doing this talk about sort of 30 years ago, you would have had sort of right-wing economists and the likes of the IMF actually suggesting that, you know, that we should, for services like cancer services, people should pay their own way, they should privately finance them. But things have changed a lot. And therefore, if we're talking about how do we get the public financing, the people we need to persuade are the ministers of finance and the heads of government. And I think we've heard some excellent presentations. Thanks to Rachel to show the dramatic need and the inequalities that exist at the moment. And then Rifat as well, showing the overwhelming economic case for doing these things. You know, sort of so now the question is, how do we use all this great evidence about the need and the benefits to persuade ministers of finance? Now, how do we get this to move on?
Just press return.
Oh, just return. No, didn't like that. Oh dear, we've got to freeze. Which one was that?
Just
that one. Okay, brilliant. Now, so this isn't going to be particularly technical. I really want to talk about tactics more than anything else, and a suggestion that some of the best ways to persuade ministers of finance and heads of government is to go the route of universal health coverage. That the politicians like universal health coverage. They understand universal health coverage. This is a definition, quite a wordy definition really from WHO, but you sort of get the idea that it's about everyone getting all the health services they need with financial protection. This definition actually spells out what we're talking about, you know, the range of services from promotive, preventive, curative, rehabilitative, palliative services. Now you can see that cancer services are riddled all the way through this, you know, so this very much incorporates everything that we can talk about sort of cancer control. And as I say, the UHC has been sort of driving the global health agenda at the United Nations with special resolutions. It's an SDG goal in its own right. And I think that this is the best way for us to get the finances that we need for the cancer control, as opposed to sort of barging into the Ministry of Finance's office and saying, no, don't listen to these maternal health people, don't listen to the, you know, the other NCDs. It's all about cancer control. I think it's a case of united we stand, divided we fall, and that cancer and cancer control can be a very, very effective way of getting the financing for the entire health system. And UHC is really fundamentally about equity and fairness. We're talking about everyone getting the services that they need. Rwanda doing a great job of providing HPV vaccines for everyone, no one being left behind. We're recognising that we're not talking about everyone getting exactly the same quantum of healthcare, that objectively some people need more healthcare than others, and people with cancer or at risk of cancer need these services. And if we are going to have this universal financial protection, you need to have a health financing system that works according to your ability to pay them. Rich people pay more in than poorer people. And this all boils down to this notion of UHC being really about healthy, wealthy people cross-subsidising services for the sick and the poor. And I'm sure a number of you will have seen this gap, but these are the decisions that policymakers are making, that if UHC is basically to fill that box with everyone being covered, with a full range of services and full financial protection, you basically got to fill that box. But then the question is, what direction do you move in? Do you sort of go for full population coverage, but maybe with a more narrow benefit package to start with? Or do you sort of really sort of try and have a very generous benefit package, but say, we actually haven't really got the resources to cover everyone, and some people are going to have to wait. And it's a trade-off between sort of the politicians, the health service people who obviously want to see the full range, but then discussions with the Ministry of Finance is who's going to pay for this. And these are the battles that we need to win. And obviously what we're wanting to see are cancer control services right in there at the beginning and everyone getting the coverage. And some suggestions as to how we might do that. And just to talk about the the health financing consensus now and really sort of suggest that that's changed. I think there is this awareness now that if we are going to have universal health coverage, that a market-based financing system, that people buy and sell services like they would a restaurant meal or buy a car or something, will never ever achieve universal health coverage. Because quite simply, where there are expensive health services, only rich people will be able to afford them. So, you know, the sort of the famous health model that has gone more down that path, the United States, about 10% of the population don't have health coverage. So really, if you are going to have this cross-subsidization happen at scale, the state must get involved in terms of raising the money, pooling the money, and allocating the resources. So this cries out for a publicly financed health system. And here I've emphasized that it should be domestic public financing. I think if we're being serious about reaching full population coverage, this notion that international aid is going to do this just isn't happening. And I think some of the political developments we've seen in the last week have made this even more apparent, that we are looking for domestic public financing and raising that money fairly being the best way of doing this. But to introduce a universal publicly financed health system is inherently political. We've seen it every country in the world, you know, the battles between those people who want it and the vested interest groups that would prefer not to subsidize the poor. So if we want to get into the financing universal health coverage, we have to think politically and be presenting the case in that way to ministers of health, ministers of finance. But it is so political, it's so hot, I would suggest that our key targets really should be heads of government. Because sadly, I think across the world, there is a tendency for ministers of finance not to want to spend that much money on health. You know, they see it as a bottomless pit, and they would much prefer to spend it on other areas. So, you know, I think the trick is that we go to a higher level. And really, just to emphasize this, is Gro Harlem Brundtland at the high-level meeting on universal health coverage in 2019, saying this point that if there's one lesson we've learned, you can only reach UHC through public financing. And this was radically different to the messages that were coming out of a number of agencies about 30 years ago. So what are the implications for cancer control services? You know, don't worry, I haven't sort of forgot this is our focus today. And really to suggest that in terms of cancer control, you know, this is good news for those of us who want to see more financing, because patently people requiring cancer services across the whole spectrum of services are very, very high need population groups. They're a very good case for having, you know, these services. And often, maybe because of the cost of treatment, you know, the expense, they've got low ability to pay for a number of these costly services. Also, so many of the services we've been talking about, we've seen plenty of evidence of this already. You know, Rifat showed that spectacularly there, are very, very cost effective. You know, they are really worth the investment. And therefore, you put these things together, they should be absolute no-brainers to be in that benefit package for universal coverage. If you need the services, the state should pay for them. Which all argues the case that these services should be predominantly publicly financed. I'm not saying exclusively. You know, if some ultra-wealthy people want to sort of pay out of pocket for experimental services, that's up to them. But really, they should be predominantly publicly financed, but not necessarily publicly provided. And there are many great UHC models where it's public financing, but the services are bought in the private sector, like France and Japan. Now, someone who I think really recognises the politics of this and is sort of aiming these arguments at the head of state is Dr. Tedros. And the WHO have been, I think, changing over the years to be thinking much more about pitching this to politicians, to heads of state. And you see that things like through the UN high-level meetings, WHO very engaged in talking to political leaders. So how are we going to sell this? And I think, you know, here are just some suggestions really. Well, first of all, using this amazing evidence and research, we've already heard a great deal tonight, showing the cost effectiveness And, you know, that we need to get much more savvy, I think, at presenting this in forms that ministers of finance and heads of government really understand. That if we can agree appropriate cancer control coverage indicators, you know, if countries are measuring how they are doing in reaching universal health coverage, it's good to have indicators to show how well you're doing. You know, are people with need getting the services that they require? And, you know, there are some services that do that very effectively, like, say, immunization rates, very easy to sort of compare. But I think we need to get sort of smarter about having some really obvious measures of coverage that we need to get into the ministers of finance. We need to really get political. We need to really think about how we use advocacy very effectively. And this might involve some of the sort of the dark arts of you know, sort of political marketing to really sort of get it on the front burner. And that means sort of fighting injustices and inequities, you know, around things like access to medicines. And we're very sort of familiar with this, that new medicines come along and some people get them and other people don't get them. And this is all sort of played out on the Radio 4 Today programme here in the UK. And that's where we've got to get involved. And very much be promoting this on a global level, you know, sort of using fora like the World Health Assembly, like the UN, to really present the case very effectively. And I just want to mention some work that we did at sort of Chatham House a couple of years ago that was looking at the opportunity to promote universal health reforms coming out of crises. Now, there might be a sort of a feeling that, you know, we've had the COVID pandemic and the cost of living spike, and any notion that you can massively increase public financing for UHC won't happen. But actually, history shows it's the opposite. It's at times of great political crisis that the UK launched the NHS after the Second World War, that Thailand launched its universal health reforms after the Asian financial crash. So we set up this commission chaired by Helen Clark, the former Prime Minister of New Zealand, and Jakaya Kikwete, the former President of Tanzania, to really sort of promote this message that now might actually be the time to launch universal health reforms. Oops. If you go, oh, you just sort of quick flash with David Cameron there. Do you know how we go back? Or is that, do I hear the other one? No. I'm sorry about that. Anyway, oh, no, it's the other way. Oh, thank you, Ashley, thank you. Great. So the point I was wanting to make here is that politicians who want to say that, you know, they're doing right by health for their population actually often use cancer as a proxy. You know, that we've seen this even with the previous Conservative government, in fact the coalition government, that as they were sort of proclaiming their commitment to the National Health Service, they say, look, we do care because we're going to provide more funding for cancer drugs. So often it is cancer that is sort of used as a measure, and I think you even saw it in the last general election here, that, you know, lack of access to cancer services was being used politically to almost like as a barometer for the entire NHS. And I think that's perfectly, you know, legitimate thing to do. And so I think that what we should be doing are looking for the political leaders who might want to do this in their own country. This is Imran Khan, the former Prime Minister of Pakistan, who because I think largely his mother had passed away due to cancer, made a big thing about launching cancer hospitals in Lahore and a couple of other cities, and was very much sort of seen to be championing universal health coverage. Now, one recognises that he's not in power at the moment, but his party won the most votes in the last election. So were things to change politically in Pakistan, maybe he would be the person to bring UHC to Pakistan, publicly financing it. And one would hope, given his previous commitments, he would give a high priority to cancer control services. And there are other leaders. We've already mentioned Rwanda. You know, after the genocide, the president really prioritised universal health coverage, and they've been very innovative in sort of thinking about how they can do this in the most cost-effective way. And I think I can be one of the first countries to introduce a universal health system. Apologies for this. I just need to kill Now President Kagame has very much made a point that during the pandemic, multilateral financing for health really fell away. And you might look at the performance of the West to say that we abandoned the developing countries in terms of running up with all the vaccines and not funding health systems properly. And he very much calling for a universal health approach in Africa using domestic financing. So maybe the crisis of the situation with multilateral financing might actually be the opportunity for countries like this to step up. So just to finish, universal health coverage and achieving it is very, very political, particularly in reaching this equitable financing system. But it's also very popular. You know, the two go together really. You know, that populations understand it and politicians understand it. And funnily enough, that it's often cancer services are some of the most emotive areas to sort of demonstrate you're doing well or doing badly. So I very much sort of see cancer control as a great way to persuade ministers of finance and political leaders to up public financing. And this is going to require a combination of tactics, using evidence, showing the technical things, but also thinking about how we use this politically. And in presenting the case, I think it's a matter of sort of saying to these actors, you know, obviously demonstrating the health benefits as we've been discussing. Rifat discussed the economic benefits, but sometimes we're not really thinking about the societal benefits and the political benefits. And quite simply saying that investing in universal health coverage and cancer control wins you votes in elections. So, and that's often the best tactic. Thank you very much, Steve. Thank you.
Thank you very much. That's very challenging and lots that we can think about and talk about in the questions later on. I'm now delighted to introduce Dr. Rocco Friebel, who's the co-director of the Global Surgery Policy Unit. He's a health economist here at the LSE and deputy director of LSE Health. He also is the director of the Executive Master's Programme in Healthcare Decision Making and is Associate Professor of Health Policy in the Department of Health Policy here. He's the Editor-in-Chief of Health Economics, Policy and Law, and he leads the European Health Policy Group, which met just recently and had a very successful meeting here in London. So Rocco, it's a pleasure to invite you to come and speak to us. He's going to talk to us about how cancer financing works. So that's great. I'm hoping we can see your slides.
All right, thank you, Rachel, and thanks to the London Global Cancer Week for partnering with us at LSE Health with the Global Surgery Policy Unit. So Rachel gave me the task to talk about how cancer financing works. I mean, it sounds like a very definite statement, but let me tell you, it's not. So I'm trying to synthesize perhaps some of the different ways of how cancer can be financed. I think Rob already elaborated very nicely around government investments and resource allocations. Again, this is a fairly high-level talk just to prompt some discussions as we go about in the panel afterwards. So I think when we talk about financing cancer care, I think we can't delineate it from financing healthcare in itself. And the bottom line is, and Rob I think elaborated on it very nicely, is cancer really, should it be the priority? I mean, Rachel mentioned lots of very concerning figures, in terms of how many people are dying, how many cases are detected, and so forth. But the reality is that, at least on a political level and in healthcare systems, I think there are multiple priorities. There are competing priorities, and cancer is a very valuable, important aspect. But it is just one priority amongst many other priorities that do exist within the healthcare system. So when we think about financing healthcare, I think there are three key main challenges. So the first one is around the development gap. So when we think about financing, there's really a clear distinction between financing cancer care in high-income settings versus financing cancer care in low-income settings. And it's very important to keep this distinction in mind. So when we look at high-income countries, and I have a lot of very nice graphs to show you in a few slides, the question is really about bending the cost curve. What we have seen is that expenditure for healthcare has really gone up quite significantly over the past 30 years or so. And if you look at the projections, it's not looking particularly promising. So as a policymaker, your objective is to try and bend this cost curve somehow, if you don't really want to allocate a lot more resources into healthcare. Whereas in low income settings, it's more about the basic infrastructure. How do you set up your system in a way that you can even provide those cancer services, that you can offer radiotherapy? So these are really fundamentally different questions, because fundamentally different questions. Rob talked about universal health coverage, so I won't really go into too much detail, but the question here is, A, how do you raise the resources to fund your universal health coverage? So Martin Lord will talk about innovative financing mechanisms and how to raise revenues. Rifat mentioned a few approaches, but another important thing is to really determine what should be part of your benefit packages that you're offering in your country. And I will talk you through some of those different aspects in a few slides' time, but really what is sort of feeding into that decision-making process around priority setting, and then creating a bundle, a benefit package that is evidence-based. And all of that within the resource constraint that exists. And then, of course, there's this global inequity issue, access disparities, external pressures. Rachel mentioned it as well on one of her slides. We have issues around climate change, we have pandemics, outbreaks in different parts of the world, and very often it's those countries that are already very vulnerable that are exposed to those issues. And all of that influences the narrative and the priorities that are being given and set within different countries. So that's just a dichotomy between high income and low income countries. It's about accessing new or accessing cancer services in the first place versus emphasizing the sustainability. So thinking about how much more do we actually want to spend or are willing to spend to provide new cancer medicines, for example, to our population. So let's, I promise you I will take you through a number of slides here, just to give you an overview of what has happened in terms of healthcare financing over the past 25, 30 years or so. You can just see those those four different colors represent different income group, countries of different income groups. On the top, you can see the trend in terms of US dollars, or share, the healthcare spending as a share of GDP in those countries, starting somewhere around 9%, 8.5% for high income countries in 1996, and really continuously rising up to about 12-13% pre-pandemic level. Then we see quite a significant spike, and that's returned after the pandemic as well. But if you look at low and middle income countries, there's a significant gap here between the high income countries, low income countries. We're really looking at maybe about 5%, 4% of spending, depending on the country where you're looking at. So really not a large percentage of GDP that's being spent on healthcare. And bear in mind, this combines government spending plus development aid plus out-of-pocket expenditure plus privately prepaid funding. So really a very small proportion. But let's see what happens in the future. We know, we now heard scaling up cancer care is really important. So you need the resourcing to make those things happen. And the Institute for Health Metrics and Evaluation has provided a very nice report recently with an overview of what they're expecting healthcare financing to look like well into the future up to 2046. And of course, perhaps unsurprising, high-income countries, we see quite a significant increase, perhaps up to 15%. Within that group, we have some outliers, the United States, Switzerland, that are already well above those 15%, but countries like the UK, I think we're somewhere around 10% or something, 10, 11% right now, but even that is expected to grow over time. But look at these countries down here. So we're saying we should really scale up cancer care. Where should the funding come from? I mean, it doesn't seem to be really a priority to invest more into healthcare in those countries. So that leads to tough choices. So this is, I thought, a very nice graph as well. Perhaps just very briefly, just the proportion of spending that is related to government expenditure versus out-of-pocket expenditure and then development assistance as well. Unsurprising, perhaps, the majority of spending relates to government health spending, with a growing proportion related to out-of-pocket health spending. I mentioned this inequity that exists globally, the inequity between spending and those spending in countries that are wealthy and perhaps the little money that's being spent in countries that are poorer. What you can see is each one of those different boxes represents, so the dark box represents high-income countries, the green box low-income countries, and you have sort of three bars. So you have the healthcare spending, so the largest proportion, almost 80% of spending, is being done in high-income settings, whereas the spending in low and sort of low-middle-income countries, so the green bar and the orange bar is maybe around 5% of total global spending. And then you compare this to the population that exists in those different countries and the need, so the disability-adjusted life years, the need within the population. And what is really surprising, or perhaps not so surprising, but even though high-income countries only make up maybe 15% of the global of the globe, they consume almost 80% of all the health expenditure. So you can just see, without going into any more detail, there's a clear mismatch between spending, just at a population level, but also in terms of need. So the need is greatest if you take the green bar, the orange bar together. That accounts for almost 60% of the need, the global need that relates to health. Spending is only 5%. So a clear mismatch. So where does all the spending, and now I'm trying to pivot a little bit into cancer care here, come from? So I pulled out this report from EcoAir, which is essentially an organization that pools data on pharmaceutical products and synthesizes those to provide insights into the pharmaceutical market. And I found those figures extremely insightful. So this is spending on cancer medicines from 2019 to 2028, and you can see that the majority of spending that's being done on cancer medicines is being spent in highly developed or undeveloped markets. So the US, Japan, EU4 plus UK. And the spending alone, the US spending on oncology, has risen from 65 billion in 2019 to 99 billion in 2023, and it's expected to grow up to 180 billion in 2028. So within a very short period of time, we can see a significant increase in spending. And again, just to point that out, so the lower income regions are those represented in orange. So you can see, these are products that are commonly not available within those markets in the first place, where countries are relying on generics and other products to, if it is available at all. But it is a very worrying trend, especially if you consider that countries, policymakers, do have the objective to bend the cost curve, try and really reduce the cost, the spending on healthcare. So one reasonable argument could be, okay, at least if you're spending that much, it should lead to better outcomes. And it was a very interesting paper published in 2022, just looking at the relationship between mortality cancer mortality per 100,000 population, and purchasing power parity adjusted US dollar spent. And ideally, on this graph, where you want to be is sort of in this box down here. So you're spending very little, and you're not really having a high mortality rate, and you don't really want to be in this box up here where you spend a lot and you experience a very high cancer mortality rate. What can you see? I mean, it's not a clear picture at all. Some countries are spending a lot, and yet they have very high mortality rates. Other countries are spending fairly little, and they have a high mortality rate. So the picture is really not very clear. And what this paper sort of concludes is that there's no clear relationship between spending on cancer care and outcomes measured in terms of mortality. Okay. So when we end up, I guess the next slide relates very closely to what Rob mentioned around what are the mechanisms that countries can use to pool resources and then ultimately channel them into cancer care. Many of you will probably be familiar with this, but I thought let me just introduce those concepts for those of you perhaps not too familiar. So we do have essentially two systems historically. Nowadays there's a little bit of a mix-up across different countries, a blended system, but initially you can pretty much divide those into a tax-based system. William Beveridge, former director of the LSE, a system that essentially relies on general taxation and an allocation of those taxes into healthcare to provide universal access. It comes with low administration costs, and addresses the need or provides services to the whole population. It doesn't mean every service gets provided to the population. So some decisions around the benefit packages do have to be made, but in general it covers the whole population. Then on the other hand, you sort of have this Bismarck model, social health insurance schemes like the ones in Germany and the Netherlands, where there's a contribution payment to an insurance fund, to a sickness fund, which then is being used to purchase services either from public hospitals, private hospitals, from different providers. I mean, two different models, different countries operate with different models, but the problem is that with the tax-based system, as Rob mentioned, it's a highly political decision. So the funding allocation becomes very political, and I mean we're seeing it in the NHS, long waiting times. So the rationing mechanism is really around delaying access potentially to services, and we can see this in the NHS, or not offering services in the first place. Those two models are very nice for high income settings, but we do have a problem in low and middle income country settings where we do have a very large informal sector. For example, it's very difficult to raise taxes or the sufficient level of taxes. It's very difficult to rely on people to make contribution payments through their employer. So there are different models that can be used, now being used now across different countries, but I won't go into too much detail. But what all of those systems require in order to address and provide this universal health coverage is about making the decision of what is being included in their benefit package. We do have NICE, National Institute for Health and Care Excellence, in this country, which has been championing this approach to using a clinical appraisal process to determine what's in, what's out in your benefit packages. We do have a group, the International Decision Support Initiative, which was initially funded by the Gates Foundation and has sort of spread out by providing services and working with countries such as Thailand, which Rifat mentioned, to introduce essentially a model similar to what NICE or NICE International has been providing the assistance to go through this rather rigorous appraisal process. But what that appraisal process entails is essentially 4 key components. So the first one is around the clinical effectiveness. So looking at the evidence, what works, what's the evidence saying in terms of the health benefits that can be accrued from a given cancer treatment. Then you have to look into the cost component. So is the product deemed to be cost effective in this country? You would say anything between 20,000, 30,000 pounds per quality adjusted life years. You would consider that as being cost effective. Other countries, for example, the United States, constitutionally says that cost effectiveness is not supposed to be part of the decision-making process of whether something should be included or not in your benefit package, which is very interesting. But at least in this country, you're looking at the cost per quality. Then you have to consider the patient and the society benefit, and I guess this is where Rifat's work is coming in. You know, what are the broader implications of providing those services to your population? And then, of course, even though something might be cost effective, it's beneficial from a society perspective, and yet there are budget constraints within your healthcare system, so you have to make tough decisions of what enters your benefit package or not. I just wanted to pick out, and for some of you this might be very familiar, some of the challenges around the decision-making process which ought to be evidence-based. So a lot of the evidence that comes from, in terms of the health benefits associated with different cancer treatments, comes from clinical trials, but all of those clinical trials, or many of them, are coming with all sorts of shortcomings, short follow-up period, an issue around surrogate endpoints, so you're not actually using mortality, let's say, as your final outcome indicator, which may only occur 5-10 years into the future. So you're using surrogate endpoints that tend to give you an indication of whether something may be working or may not be working, partly because you as a regulator, you want to obviously promote early quick access potentially to new medicines. At the same time, you do have the producers who are putting pressure on you because they want to obviously maximize their profits and not feed into their patent period too much. And then of course we have advocacy groups who want to have quick access for their patients that they represent. But that leads to all sorts of issues. And my colleague Hussein Nachi, I think I put his reference here as well. He looked into 223 FDA-approved cancer drugs who have been approved through an expedited process, but only based on a surrogate endpoint. And he looked at what was actually, once they had received market authorization, once they've been introduced, what was actually the survival benefit, following a five-year period. And what's interesting is that about 70% of all products, all of those cancer drugs that were eventually introduced into the US market, didn't show any significant impact in terms of life expectancy or mortality reduction. Some of you, the critics in the room, you would probably argue mortality is maybe not the outcome you should be looking at in the first place. But if you try and build your economic case, which was done by the previous presenters, mortality has always been emphasized as a key determinant of productivity and a key indicator to assess how well we're doing as a healthcare system in terms of addressing the cancer burden. The other thing, and I'm just a little bit aware of the time and probably talk a bit too much here, is this issue around getting the drugs and getting the new medicines to low middle income countries. And again, a colleague of mine here in the Department of Health Policy, Olivier Wouters, he just published a study in Health Affairs last week looking at the time it takes for cancer drugs and other drugs that are part of the WHO essential medicines list, so drugs that are considered to be highly effective, cost effective, and should in theory be made available to anyone around the world. How long does it take for those drugs that are launched in high income countries to actually trickle down to be available in low middle income countries? And what he found, or what they found in this study, is that on average it takes about 8 years from a drug to be available in a high income country for the same product to be available in a low middle income country. And you can see sort of global distribution of that. And the final point that I wanted to make before I finish is just to think critically about the implications of development assistance for health. And Rob touched on it very briefly, and I absolutely agree with him that countries should not rely only on development aid to finance their health priorities or to finance healthcare in the first place, and they ought to be looking into domestically raising funding for their healthcare systems. I mean, lots of very nice colors here, but look at the orange line. So, cancer classified as a non-communicable disease. Within development assistance for health, it's really playing a very marginal role. And remember, there are many countries, especially the poorest countries in the world, who are overwhelmingly relying on development assistance to finance their healthcare. Cancer is not on the top of their priority list. In addition to my affiliation here to the LSE, I'm also affiliated with the Center for Global Development now for the past 6 years or so. And they have come up with this, they've just published very recently a very interesting case study or simulation study to try and see of how, can countries that are aid dependent or, the recipient of a large proportion of development aid and use their own domestic financing mechanisms to basically get the most value for the money and better reflecting priorities that are set locally rather than determined by outside actors. And they termed it the new compact. So if you get a chance, look it up. They simulated it in the case of Ethiopia, and they essentially identified 3 key steps here. So the first one is about having a locally led evidence-informed prioritization approach. So country institutions, they should be setting, or countries should be setting their own health priorities. They shouldn't rely on outside actors to do it for them. They should be thinking about the domestic, resource allocation. Countries should take ownership over determining, where do they get money from, the financing from for the healthcare system, and what should be part of their core packages. High priority services based on the priorities that have been identified previously. And then essentially the development aid is a top up to that. So you're focusing only on those conditions, on those services that are highly cost effective, and then you top that up with funding that's available from donors. Okay, in summary, I think the message is clear. There's growing concern about the financial sustainability within high-income countries, especially if you look at the pipeline that I showed you in terms of new cancer medicines. Countries, high-income countries, will they be able to still afford the most novel, innovative cancer drugs in the future? It's a political choice. I think that's all I have to say. And then the second point, if you just look at spending resources that are being allocated to healthcare within low middle income countries, it's not looking particularly great. So I think I'll leave you with that and we can discuss it later in the panel. Thank you.
Thank you, Rocco. And our final speaker here this evening is Dr. Marcello Di Finici. He's both a medical doctor and a PhD health systems economist. He's going to speak to us this evening about one of his interests, which is about hypothecated taxes to fund cancer care. We've heard a little introduction to this from Professor Atun earlier on, and Martelot's going to come and speak to that now. So thank you very much, Martelot.
Thank you very much. Thank you, Rachel, for having me, for inviting me this evening to speak, to contribute to this conversation. And good evening, everyone. The previous speakers have actually made the work easier for me. Rifat already pointed out earlier in the beginning about, already pointed to syntaxes as an option for raising domestic resources. And he gave an example of Philippines, where actually has raised huge resources there to contribute, they are using for UHC. Rob also pointed out, painted a picture of, or described how we can build political momentum around UHC. And then, of course, Rocco talked about how to finance, how it works, the challenges of prioritization, because the governments need to deal with a lot of competing priorities. So, and then one thing that came out clearly from all these conversations is that in the low and middle income settings, the need is huge and is going to be rising in the coming years. And yet, the expenditure there is the least. So I am going to be looking at pro-health taxes for financing cancer care. So we are going to narrow down to one low-income country to see the opportunities or the potentials for earmarked financing for care, for cancer care. So what are pro-health taxes, also called sin taxes? So these are essentially taxes, excess taxes the government will impose or levy on certain products that are considered harmful to the population. So for instance, cigarettes, sugary drinks, alcohol, and more recently we hear about fossil fuels. So how does it work? Basically, you impose the taxes, you expect that the retail prices will increase. What does it do? You discourage or disincentivize consumption. So in one hand, you're promoting public health, and then you're also raising revenues, which ideally should be channeled to public health, but we would also probably see that it doesn't always happen that way. There are basically two common forms to this. You can have the ad valorem form of it, in which case you're imposing a specific percentage, let's say 20% extra tax on the price. So whatever the price is, a certain percentage. The good thing with this is that normally, okay, so there's also the specific type where you put a specific amount, let's say 20 euros per unit of the product. It could be per liter, it could be per stick of cigarette, it could be per kilogram. The percentage one, the advantage there is that even if there's inflation, where all the other prices are rising, you still have the percentage there. So it's more immune to dilution from inflationary changes. Okay, so this is a bit just background for pro-health taxes or sin taxes. What is it about cancer care in Nigeria? So in Nigeria, the Federal Ministry of Health, you have the cancer control program, have National Cancer Control Program. It's more like a desk within the ministry. Some people have argued that given the epidemiological transition and the rise in prevalence and incidence of cancer, maybe it's actually necessary to have an urgency like we have for HIV. Then, of course, they have the National Strategic Control Plan. The current one is 2023 to 2027, which replaced the last one that ended in 2022. There are some efforts to upgrade some national referral hospitals at different regions and make them national centers of excellence for cancer. However, we don't really have any earmarked funding for cancer in Nigeria. And to be fair, to a very large extent, cancer is still not there. I mean, the attention is increasing, but it's still not where you would expect it to be given the threat. So 2020, Roche, the company, mobilized some private players, and of course, in collaboration with the Ministry of Health, to launch what they call the Nigerian Cancer Health Fund. So what they are doing is actually started like a pilot program in different hospitals. They try to pay for the care of cancer patients. But then what you have here really is just like a drop in the ocean compared to the need. So the question then, or what I want to look at is, what is the potential, what is the possibility of actually raising some earmarked funds from sin taxes for cancer? Now what we are going to do is that we are going to draw from another study that we've done, looking at the potentials for raising revenues for surgery from sin taxes in Nigeria. A bit of context to that, in 2019, Nigeria launched National Surgical Obstetric and Nursing Plan, in line with the recommendation of the Lancet Commission on Global Surgery. Of course, we know that so many, as the last count, about 10 countries already in Sub-Saharan Africa have these plans. But financing is always a problem, and then there's been a lot of attention to, again, sin taxes as a way out. Then, coincidentally, end of 2021, Nigeria then introduced a sin tax, a policy of tax on sugary drinks. They placed it at 10 naira, the Nigerian currency, per liter to discourage consumption and raise revenues. So what we then went in to do was to see how and to what extent sugar taxes can be leveraged to finance the implementation of the National Surgical Plan that was drawn by Nigeria. This study is already published. It's freely available on Google Scholar and Health Policy and Planning. In case you want details, you could find this online. But just briefly on what we did. So there were two components to this study. One of the first part is the quantitative part of it, where we modeled the revenues that we could potentially realize from the policy. And then the qualitative part, where we wanted to explore the political economy or the dynamics around the resource allocation. What is the possibility that the finances or the funds, revenues could actually go into surgical systems development? So, like, just for clarity, this study is about surgery broadly, but the lessons there actually are very much applicable to cancer care specifically. For the quantitative part, basically this was based on the elementary economic principle of elasticity of demand. If you increase prices, you would expect that the demand will drop. So the question is, so based on your new consumption rate, you can calculate how much you're probably going to get in 1 year and 5 years at 10 naira per liter. Then the question is, how do you determine the drop, right? Of course, this actually has a lot to do with the own price elasticity, the cross price elasticities, pass-on rates. For one of time, I wouldn't get into all these details, but again, they are in that study. But for the qualitative part, we spoke to a wide range of stakeholders and subject matter experts, from the policymakers, from the Ministry of Health, from the Ministry of Finance, from global surgery experts, practitioners and champions, civil society organizations, also clinicians from different fields, different specialties, internal medicine, pediatrics, public health, because we wanted to see their disposition to channeling these resources to surgical systems development. And then we also conducted document analysis, and then the analysis of all the data we collected was based on Campbell's framework, which is actually a recognized framework for political economy analysis. So what did we find? So in the first, on the average in 1 year, well, our estimate indicated that the country could generate 38 million USD in 1 year, and over 5 years, about $190 US. Because of uncertainties around the variables we used in the model, we had to do, of course, as you expect, scenario analysis and sensitivity analysis, trying to play around some of these figures to see what if this, what if that, what do we get? What is most relevant here is the last one, the bottommost one, that's line 8, serial number 8. Because currently it's at 10 naira per liter, that's about 7% of the price. That is the rate. So what if we take it to the WHO recommended 20% ad valorem rate? Because from evidence, at that rate, you get the best in terms of the impact on reduction in consumption, and you also get more resources. So this is why they recommended this. So if the rate would go to 20% ad valorem, the country or Nigeria would be generating $85 million per year. Now, having seen what is realizable, what is the probability or the possibility of getting this to the surgical system, the national plan which the country developed? So what we found out was that the revenues generated, actually, they go into the single national revenues pool, right? So every other thing goes there, even things are not related to this. And then, so the revenues are not ring-fenced. The act that actually created this did not specify that it should go to health, even though in theory, sin taxes or pro-health taxes are supposed to be for health. We also saw that there's actually very strong diverse competing interests within and outside the health sector. Outside the health sector, for instance, even people from hospitality industry are arguing that the monies or the money generated should come to them because the drinks in question is in their sector. Within the health space alone, you see varied interests. So somebody in surgery feels like, oh, you should come to surgery. Somebody in internal medicine feels like, oh, why don't we put this to internal medicine issues and all of that. So you still see some kind of, even if it's subtle, interspecialty rivalry. And then one thing that came out clearly is that within the health space, even though there's an existing national surgical plan, surgery is not a priority. It's not even there. It's not even on the top 5 as far as they were concerned. And this was very uniform across, whether it's from the public policymakers, whether it's from the clinicians. It wasn't just a priority for them. So what were they focusing on? Infectious diseases. And NCDs here were like hypertension, diabetes especially. The good thing is, what is interesting is that most of the people we interviewed actually agreed that primary health is very important. So there's that convergence of interest there. And I'll tell you why this is important, or this is useful shortly. So what are the implications of these findings? Substantial resources are potentially realized from sin taxes and pro-health taxes, because what you just looked at there is sugary drinks, SSBs. That didn't look at alcohol, that didn't look at tobacco. And of course, even the current rates are very low. So you can imagine what's happening if you actually take it up. It's important that from beginning that the revenues are earmarked, are ring-fenced for health services at least, even if not surgery or not cancer, as the case may be, at least for health, because that's actually the principle around it. It's also important that the tax rate should align with WHO recommendation. And shortly we'll also talk about why countries have difficulties getting to that level or to those levels. So we've seen that even though there's an existing national surgical plan, but it still lacks the political momentum needed to actually get funded. And that's why Rob's presentation becomes very, very, very relevant. How do we raise the political momentum around specific issues? It's important that we actually leverage points of common interest. Now, this again takes me back to Rob's presentation, talking about framing things through UHC. Everybody agrees, everybody sees the importance of UHC, everybody loves UHC. He already said that. It also was also what we found, that everybody was happy with primary health, universal health coverage, and pretty much the 2015 World Health Assembly Resolution 68.15 actually clearly recognized surgical care as a core component of universal health coverage and primary health. So what framing it in that way is already aligns with universal understanding and universal beliefs. Okay, so that was specifically about syntax, about sugary drinks. But just one slide before I conclude. So it's also been argued that maybe we found low political momentum around surgery in the context of the sugary drink tax in Nigeria, because there's no obvious link between surgery and the sugary drinks. So, but in the context of cancers, tobacco, you can easily link tobacco clearly, directly to cancers, lung cancers especially, which from the earlier presentation from Rachel, we saw that it was like #1, if I'm not mistaken. So what do we know about that in Nigeria? So Nigeria already introduced in 2018, so we didn't study this is just what is out there already. 2018, tax on tobacco, cigarettes, and all the other tobacco products. So it's mixed. It has changed a lot since that time, but currently it's at 30% of the factory or the manufacturing price. That's the ad valorem part. Then there's also the specific part, which is 84 per pack, and the pack has like 20 cigarettes. Cumulatively, the two components actually constitute about 25% of the retail price. What is noteworthy here? 25% is a far cry, is way below the WHO recommended 70%, right? So there's still huge room there. Even the 30% ad valorem component is still below the ECOWAS region recommendation of 50%. And at 84 naira per pack, that is there now, for it to reach the ECOWAS regional recommendation, it should be around 122. So what's the point I'm going to make? There's still a huge room for scale up in terms of what is there now. Then if you look at the tobacco taxation, the score of the regime, the current tobacco regime in Nigeria now is 1.25. The highest is it's over 5. So 1.25 is still less than the regional average of 1.6 or the global average of about 2.2. So a lot could still be done. Now, a study already showed that in 2020, Nigeria generated 155 million USD from the tobacco tax. And we see that another study also said that if they were to increase to the ECOWAS recommendations, the taxes or the rates, the smoking will reduce by 32%, and then the revenues will increase by 127%. The question that you would ask is, I mean, this is common sense. If by raising the taxes, you would have like best of both worlds, you're promoting public health, you're also raising revenues. Why don't we just do it? And then that's where the industry pressure comes in. So the tobacco industry, or whether it's the sugary drink industries, the people that make the soda and all of that, these are very powerful entities. They have huge resources, and they can go any extent to stop what you're doing. So usually what they do is that they argue that, oh, if you do this, if you raise it, if you introduce it, or if you raise it, I mean, the industry is going to suffer, people are going to lose their job, it's going to affect the economy, tobacco farmers are going to lose, be bankrupt, it's going to increase smuggling of tobacco products. It doesn't even work, by the way. It doesn't have any impact on consumption. For every argument they've made, there's a large body of evidence actually showing that those are not true. So essentially, those arguments are simply, they want to protect the money they are generating from, it's all commercial, it's all profit oriented. It's not anything about the public or the macroeconomy of the country. So you realize that you're actually playing or competing against very powerful forces and entrenched interests. And then another thing there is the revenues also, like in the country now, similar to what we saw with the sugar drinks, is just going directly into the general public pool. So if you would want these monies to come, at least to health sector, or if you want specifically to cancer care, then it takes us back to all the earlier presentations. We need to play the politics, which is exactly what Rob was talking about. And then the evidence that Rifat presented, that's the first presentation, about the economic argument for it is very powerful, because a lot of times these decisions are not actually taken by the Ministry of Health, but by Ministry of Finance. For them to just, so the most likely thing that would move them is the economic argument. What really is, if we invest XYZ in surgery or in cancer or in this, how much do we get in return as a country economically? I mean, health is very important, but they also need the economic part to, for them, this most probably economics more that appeals to them. Of course, Ministry of Health, there are more health people, but so we need to understand different audiences and different things, different tools we need to approach them either. And so we need to put all of these things, all the evidence we need to actually make a case, one, for introducing the syntaxes where necessary, where they're not there already, two, taking them close to the level where they should be, and then again, ring-fencing the resources for healthcare services, at least broadly or specifically as the case may be. Thank you very much.
Thank you very much, Martelot. If I could invite the panel to come up to the seats here, and there should be a microphone for each of you. There's two there. Okay, so there's some time now for questions. If you're in the room, just raise your hand, and when you ask your question, if you can just say who you are, and we've got some coming in online. So we'll start with the lady there.
Hi, so Katie Waker, so I'm sort of
Microphone.
an NHS.
Hang on a minute, we'll bring you a microphone so the people at home can hear. Can we take one of those?
Thank you. Is that on? Doesn't sound any different, does it? Do you think that's working?
I don't think this, is that one working?
I'm not sure.
You'll just have to shout then.
Yeah,
I'll shout really loudly. So, hi.
You won't have to come and shout into that one, maybe.
It's okay.
Is it okay?
I'll repeat
Okay,
it.
you'll repeat it. So hi, so Katie Waken. So I'm a sort of an NHS clinical oncologist, and very recently the UK's Health Secretary Wes Streeting said that we waste between 10 and 14 billion pounds a year in financial mismanagement in the NHS. And that's actually a very similar amount to our total spend in the NHS on cancer care. So you're sort of thinking about Rifat's model, for every pound we spend, we lose a pound in mismanagement. And I just sort of wonder, you know, on a global scale, that must be, you know, even more significant. And in sort of the financing, you know, policy world that you live in, you know, how much discussion is there about that sort of loss of money, and sort of what can we do about that? And does that factor into the models that, you know, Rifat and others present?
Who'd like to take that? Bob, do you want to take
I'll
that
have
first?
a go.
Meave, can you bring the
Oh,
things back?
Yes, it's a very, very, very good point. And WHO, I think, often come up with a rough figure of about 25% of health spend is wasted on inefficiencies. So it's obviously vital that as we present the case to ministers of finance and heads of state, that we can demonstrate that we're using the money efficiently and not wasting it. So Wes Streeting is absolutely right, and there are potential to reduce inefficiencies. But I do think, again, you look at the financing models, and you know, the United States spends 18% of its GDP on its health system. A third of that is administration. People just like running around chasing bills, denying claims. You know, there are some ways that you finance the health system that are inherently inefficient, and the worst is private health insurance. It's just an absolute waste of money. So in many respects, this doubles down on the argument that it is much more efficient to publicly finance your health system and, have, say, for example, the NHS purchasing its medicines on behalf of 70 million people and getting much better prices, that some of those rocketing prices for cancer medicines in the US because of it's privately financed and it's all fragmented. So a lot of the efficiencies can be improved by switching to a publicly financed system.
Thank you. Rocco, do you want to come in on that?
Yeah, I mean, maybe just very briefly. I mean, there's sort of two types of efficiency we're looking at. So allocative efficiency, technical efficiency. Allocative efficiency is, in my view, what the NHS or NICE, has been doing fairly well. So it's about determining, what's the cost effectiveness, the benefit attached to your to a new product, and whether it meets this cost per quality threshold and should be entered into the market. So I think the NHS is doing very well in this allocative efficiency. What the NHS, and I think this really goes back, a few decades now, trying to address this this technical efficiency. So how do you get healthcare providers to work better, to create more value in the work that they do, and how do you incentivize hospitals to be more efficient in the way they treat their patients? And I mean, the NHS has been, or from a political point of view, there has been a lot of experimentation over the last years, whether it's around provider choice, whether it's about using financial incentives to encourage certain behaviors. But there are, I think over the past 15 years or so, there have been attempts to try and address this technical efficiency. But nonetheless, I mean, you're still looking at, I think you mentioned 14% of inefficiency.
Thank you. There's a question coming on online, which I'm going to ask Martilo to start with. This is from Damali Napoleon, which is about how low-income countries can improve cancer funding. They raised the issue of Uganda, which currently only spends 0.7% of GDP on health funding, which is way below even the 4 or 5% that Rocco showed in his slides. You gave one example of hypothecated sugar tax in Nigeria. Do you think there are other approaches which African countries, which at the moment have very low levels of spending, could use to improve cancer care funding?
Yeah, I mean, that's an interesting one. I would just that probably takes us back to what Rocco was highlighted. There are different approaches to this, and I will look at it just spending on healthcare generally, right, for this conversation. What is happening in Africa is interesting because the African leaders generally, I mean, it was the year 2001, actually had a meeting in Abuja and agreed that every country should allocate at least 15% of its annual budget to healthcare. Apart from one or two countries, a whole lot of them actually have allocated very far. So a lot of them 4%, 5%, 6% to healthcare. So that's from just budgetary allocation alone. So from that alone, we see that there's still huge room for improvement. At the end of it, beyond budgetary allocation, another one I would consider probably low-hanging fruit, probably not that low, but a good one, is the health insurance system, the social one. And Rwanda gives us a very good example of doing these things. Rwanda already has like over 90% of its population covered because it has a combination of the national health insurance system and the community health insurance system. So with that, it was able to cover people in the urban area, people in the rural areas, whether it's because the problem, like Roke already mentioned earlier with the regular social insurance program, is that if you have a huge population in the informal sector, you can't really get them into this scheme, right? But if you can combine it with the community health insurance scheme, it works well. But of course, that also needs, you need actually to also be very innovative about it. They also need a lot of funding. You need to put in a lot of funding into this because the population that is not working and is not able to pay premiums, somehow we have to account for that. But I think that a lot of people, a lot of countries in Africa can look at what happened in Rwanda. And even if we take Nigeria and Ghana, for instance, two of them started health insurance program schemes around the same time, 2005, 2006. Ghana has gone over 60% coverage. Nigeria is still struggling around 5%. So a part of it also has to do with political will. So I feel like countries that are not doing well in that region can actually learn from the few that are doing well, right? And then, of course, I mean, apart from these ones, there's still a huge room, there's a large room for involvement of the private sector. With what happened in Nigeria during COVID, how the government actually worked with a huge part of the funding that the country used or it's responding to COVID actually came from private sector. So there are lessons we could learn from there to respond to whether it's health generally or cancer care specifically.
Thank you. There's a question from Professor Stephen Chadwick about, given the financial pressures of global warming, particularly in the global south, and the other things that we've shown tonight about the projected rise in cancer cases in low and middle income countries, what is the panel's views about setting up an international fund which would finance cancer care in low and middle income countries? Is this a natural extension of the healthy, wealthy subsidising the poor and the sick? You've emphasised it at a country level, but should we be doing that internationally?
I may not be super popular in saying this, but I don't think that will work. I think in an ideal world, ethically, we ought to do something like that. You know, we've had attempts with the Global Fund for AIDS, TB, and malaria, and that has helped fill a gap. But I just think, looking at the real politique of the world at the moment, and just looking at our behaviour of rich countries during the pandemic with this massive global crisis, where, you know, when there was scarcity for vaccines, we ordered them. We didn't fund Act A properly and these multilateral things at the height of a pandemic. And then we also blocked tech transfers to developing countries to develop their own medicines. We behaved abominably. And then in the midst of that, countries like the UK abolished DFID, cut its health financing, and got away with it. So I think if you look at this at the moment, the likelihood of creating an NCD fund, a cancer fund, a diabetes fund, I mean, it's for the birds. It's just not going to happen. And in many respects, I think the faster that we realise that, and President Kagame has realised it, we talk about Rwanda, he says we've got to pay for this ourselves. And I think that might just be the way it's going to go. So unfortunately, you might say ethically we ought to, but it's not going to happen. And with Donald Trump in the White House, you can forget it. I'm sorry.
Okay. One maybe for you, Rocco, which is coming in around high-income countries. Can even high-income countries, this is from Dr. Chakrabarty, can high-income countries really afford to access high-quality care for cancer and other complex conditions if they do not focus on prevention? And would that be more cost-effective?
So I think, I mean, this is the question of the hour, really. Where should you focus your efforts? Should it be on prevention, primary prevention? I don't know, perhaps secondary prevention, or should it be around treatment? And you know, in the run-up of this panel, I was just looking at the literature, and I think there was a very nice study in the Lancet, just quantifying, you know, how much of the burden is actually, you know, down to preventable, or how much of it is preventable versus treatable. And it was about a 60-40 split. You mentioned vaccinations, you know, all these types of things that do impact on the burden. And in my view, you know, it's perhaps the most sensible place to start, especially if you don't have large resources to provide a healthcare system. But at the same time, because it is so political, as a politician. It's nicer to stand up and say, look, we have a cancer drugs fund, we're covering novel medicines for our population. Whether it's, creating the value that you would get from focusing it on other areas, that's a different question. But politically, it's a much nicer proposal to offer to your population than saying, I don't know, we're running HPV vaccination program, and maybe in 20, 30 years you're going to see the effect, or in 15 years you will see the effect, which goes beyond the election cycle. So I think politically it's perhaps a bit more of a difficult sell.
There's a question come in from Dr. Koal about the role of insurance companies, particularly with respect to the experience in the USA during President Obama's time, which brought, it says here, 46 million Americans into healthcare. Do we feel that there is a role for insurance companies globally? I mean, it's not something that's a big part of the British health economy, but do we have examples where that would be workable?
Personally, I think no. Honestly, I think if you're looking at this notion of universal coverage, it's so much more efficient to create the biggest pool you can, where you sort of use all the resources from the rich, and then, so you pay in according to your ability to pay, and you take out according to your need. And that just cries out for publicly financing it. And you can do that through social insurance contributions or tax financing or sin taxes. Much, much better do it that way. And, what is the purpose of insurance companies creating confusion? I mean, you talk to American friends about the annual nightmare of deciding what policy they're going to, what coverage they want, what co-payments. It just adds unnecessary costs. And honestly, I do not see any value whatsoever in private health insurance.
That's very clear. We have a question at the back.
Oh, hi, I'm Dr. Mark Lithgow, so I'm a medical oncology registrar. I think resident is the new term. So I just had a question. I think you've highlighted very nicely about the rising cost of new cancer drugs and potentially how that's potentially impeding universal health coverage. Now, in the US, they've just launched the IRA, or Inflation Reduction Act, and I think the Biden sort of cancer moonshot said this is going to be an effective means to reduce overall drug cancer prices, not just in the US, but globally. I think there was one cancer drug, ibrutinib, which was included. Now, this is going to be expanded to probably around about sort of 20 to 30 drugs. I just wondered if the panel felt this was going to be a potentially an effective sort of vehicle for sort of driving improved sort of global access to expensive cancer drugs.
So I think, it's quite interesting. I mentioned it in my discussion. So the consideration of cost effectiveness, constitutionally, is not something that should be taken into consideration in the United States, whereas in the UK, it's a key indicator of whether something makes it to the market or not. But at the same time, I think it's about 100, I don't want to give the wrong figure here, but well above 100 countries in the world who are looking to the US and the FDA approvals with regards to cancer drugs, with any drugs, and adopting, taking whatever the FDA is approving in the US, as a given, partly because there's not the infrastructure and the capacity to do their own health technology assessment in country. And I think historically, the US, and I think this graph from Equia showed it quite nicely, the US is the market to make money. If you're a pharmaceutical company and you want to produce a cancer drug, the US is the market where you want to launch the product. That's where you're going to make your most profit. And because of the mechanisms in place in the UK and other healthcare systems, it's just not as attractive, because politically, the argument is we only have a given pot of money available to fund cancer drugs. So, if it exceeds a certain threshold, we're just not going to fund it, which is undesirable potentially for some patients who may be benefiting, who would potentially benefit from it. But I'm not clearly answering your question about the Inflation Reduction Act, but I'm sure you have some strong thoughts on this.
Well, just I think more radical things are really needed in the US, really, and you see this tendency for oversupply. I was just in the US last week, helping out with a rather disastrous election campaign there. But you know, it's you put on the television and people just bombarded with advertisements about pharmaceuticals, and you know, if you have these conditions, talk to your doctor and get switched to these other medicines. And you just see them getting ratcheted up and up and up the prices. So I think, you know, the rapacious nature of the big pharma companies in the US, unfortunately, does drive up costs across the world. And I think there's a much more radical approach. You know, I know it's unlikely under the Trump administration, but who knows in 2028, there's, you know, a leader might emerge to bring some sanity to the health market in the US and introduce a single payer system.
If I could just come in there, really bringing together something that Marty Lord said and the converse that you said. In Rob's talk, he encouraged us about advocating for spending on cancer care, and indeed in Rifat's talk at the beginning about the benefits of investing in cancer care. And yet it seems to be a huge problem. And yet, as Marty Lord said in his talk, and it's just been indicated now, the lobbying and advocacy power of the pharmaceutical companies, the cigarette companies, the sugar drinks industry, what can we learn from them? Because they must be doing something right. Come on, Marty Lord.
At least from my own, from the context, I'm very concerned with, like, let's say in the Nigerian context or the low and middle income settings. In terms of, I'm not sure what we can learn in terms of, I'm sorry to say this, but you also know that sometimes they go out of their way. Sometimes they even employ means that you wouldn't want to employ. And I'm being very careful with my claims, but for us, the most we can do, I mean, as advocates, public health advocates, is use evidence and then speak to the policymakers at different levels. Sometimes we are not even actually doing enough, even within the limits of ethics. Maybe that is what we can learn from them. The point I was trying to make is sometimes they also even do go out of the ethical bounds, which is not what we want to learn from them, right? But even within the ethical limits, within what is decent, sometimes we probably just stop at Ministry of Health, for instance. Okay, so recently we did a review of national surgical plans across 10 African countries. And then we saw that in the planning, and these are very expensive documents. In the Nigerian one, for instance, is $20 billion US. The total cost over 5 years. But then for most of them, we didn't see the Ministry of Finance being involved. So the question is, how do you develop a plan of that magnitude, and you want it to be costed with public finances, and then the Ministry of Finance is not involved? The Ministry of Health alone cannot give you such resources. And then, of course, you have the Senate, where you have, for most places, where you have the appropriation, the budgetary allocation, or at least is passed there. They actually handle it. The people, the industry people, they have access. They have all these people, the senators and all the big people, on their speed dial, right? A lot of the health policy advocates don't get to that. So we also need to get to that level, start playing at that level. That's probably the only thing. And then, of course, we need to intensify because for them, they argue, and then they probably even sometimes make it a motive and say, oh, people are going to lose their jobs. So we also need to be more ingenious in the way we present our arguments. That's probably the learning points there.
really, I think you've been very diplomatic, you know, sort of saying that what we're talking about in many of these instances is just downright corruption, and, you know, sort of the power of the lobby to sort of persuade governments to sort of spend inflated prices. And, you know, we saw it in the COVID response here in the UK with the PPE, and therefore it is the role, I think, of civil society and the media to hold governments to account, hold companies to account, and not waste public money on sort of inappropriate technologies and, you know, dodgy PPEs. So I think, again, it comes down to the politics of all this, and for us to really sort of hold our governments to account to make sure they spend our money wisely.
Okay, well, in the interest of time, they'll be turning the lights out very soon, so I think we should give the last question over to one of the LSE students, John Smith, who sent in a question from Newcastle, and just want a very short answer from each of you on the panel. What one change of policy would you like to see which would have the biggest impact? Would you like to pick one thing each? We'll start with Rocco on the end.
So, I mean, there's so many, but I think one of the most critical things is for countries to determine a mechanism or set up a mechanism that is essentially allowing them to build up evidence or benefit packages based on evidence, and, you know, have a robust mechanism in place to appraise the evidence that is there, look at the priorities that exist within the country, and allocate resources accordingly.
Thank you.
Our Commission for Universal Health found the order of magnitude, you need about 1% of GDP additional public financing to launch effective UHC reforms. That's what we did in 1948, the Thais did in 1999. It would be great to see countries like Nigeria find about 1% of GDP, most likely from its oil revenues actually, and provide universal coverage. And you can do it, others have done it.
We've all seen that we cannot continue to rely on international development assistance. So there's more focus now on the domestic resources. The one area that I think will make a huge difference is the health insurance system. If we can get it right, let's say Nigeria, for instance, have a functional health insurance system where we at least have the formal sector all in the pool. The informal sector, there are also some very creative ways. There are some people in the informal sector that are not necessarily poor, but it's just that they are not formal. There are still ways to get them into the system in an innovative way, and then make special provision for the vulnerable groups. If we're able to get this right, I think that would make a huge difference.
Thank you very much. So I'd just like to draw things to a close now. I think we'd like to thank our panel for their speaking and for answering the questions. Thank you. Also like to thank all of you here in the room, and for those of you online who've attended and taken part in this meeting. Thank you to Professor Atun for his contribution with the virtual presentation, and thank you to the London Global Cancer Week for inviting us to take part in this week. They have a number of other events during the rest of the week, and I could direct you to their website if you've got any time over the next 3 or 4 days. I'm sure you'd be most welcome, and most of them are online or hybrid events, so that people in all parts of the world should be able to take part. Thank you very much for coming. Thank you to the Royal College of Surgeons, and particularly to the London School of Economics for hosting us here this evening. I wish you all safe travels back. Thank you very much. Thank you.